Hi, this is Dr. Ray, and I'm here today to talk to you about neuroanatomy of the pons. If you haven't seen my introductory video on the brainstem, you might want to watch that first. Pons is going to develop from the metencephalon. The metencephalon is the part of the neural tube where the pons and the cerebellum originate from. The walls of the metencephalon are going to move laterally just like it did in the medulla oblongata because of the pontine flexure and because of the growth of the fourth ventricle here. All right, and so you're going to have displacement of the alar and the basal plates. And you're going to end up with this kind of configuration very similar to that in the medulla oblongata. Is everything the same in every slice? You're going to be able to find all of these functional components? No, because you have different nuclei that are in different levels. And so it's not going to be exactly the same as the medulla oblongata, and I would not sit down and try to memorize the orientation of all of these columns per se. But the three general rules that I gave you about motor being medial and what sensory being lateral and how down the middle is going to be the general somatic efferent, they hold true here, and special senses is most lateral. Okay, and so the other real cool thing about the metencephalon is the cerebellum is developing from the posterior or dorsal side, and so here you have at the beginning a small swelling, and the swelling enlarges to where it actually overlaps where the medulla oblongata is located and the pons. You also have invagination of the arachnoid, and you have formation and growth of the choroid plexus, which is going to secrete cerebral spinal fluid. Do you all talk about that? Yeah, you talk about that in some other location. All right, great. And so you also end up with these neurons that are going to migrate from the alar plate, and they're going to grow with this cerebellar swelling. And these neurons are going to make up the neurons that are in the cerebellar cortex, and also deep nuclei within the cerebellar that are called central nuclei. And this is a cadaveric specimen. It's actually the junction between the medulla and pons. Here you can see central nuclei of the cerebellum, and the gray matter of the outside of the cerebellum are the cortical neurons. So they came from the pons. So it's not really a hard stretch to understand that these two structures are related to each other. There's going to be a lot of connections between the pons and the cerebellum. And anything that wants to make it to the cerebellum, with a few exceptions of these other, the inferior cerebellar peduncle, is going to probably come through the pons somehow. Some of them synapse in the pons, and some of them come through without synapsing. Okay? So that's to be continued. Here's the architecture. This is all to be continued later on in another anatomic lecture on the cerebellum. So let's just isolate now, where is this pons? You're going to want to be able to identify it no matter what medical image you're looking at that includes it, or at least rule it out. The pons is going to be just below the midbrain or caudal to it. It's going to be rostral to the medulla oblongata. When you're looking at a sagittal section here, hopefully the cerebellum is a good orientation spot for you. Looking at the widening of the fourth ventricle, the ventricular system above and below widens into this large rhomboid-shaped fossa. And then you have this large pons with a basilar part here that sticks out in the ventral side. So what are some nearby structures? These are structures we talked about yesterday, kind of in the same location, just a little superior to the medulla. And so if you have any type of growth or increase of blood, fluid, or mass of the brain itself in the posterior cranial fossa, it's going to affect, it could very well affect the pons. Or if you have a tumor up here in the pituitary area, it could very well affect the pons as well. So this is a medical image, and you should get comfortable with looking at lots of medical images and asking yourself easy questions, and we'll just get further and further, because eventually you're going to want to know what's located approximately mid-pons versus caudal pons versus rostral pons on an image, because that's how you're going to input your patient's data into your mind. So you're learning all this basic information, but eventually it's all going to be transformed to you into looking at patients' medical images and looking for lesions. All right, so on the ventral side, the pons is a lot simpler on the ventral side than the medulla oblongata. We have this basilar part, these large collections of axons, a lot of which you can see are running horizontally And because they're coursing to the cerebellum grew out from the pons, and it has lots of connections that come from the basilar pons. And another great differentiating feature is that we have a very large cranial nerve 5, that comes out on the ventral side, and it demarcates the ending of the pons and the beginning of the middle cerebellar peduncle. So that's an easy way to find it in lab, okay? And then we have 5 is going to emerge from the pons. We have other cranial nerves. I've reiterated that cranial nerve tangent on the pontomedullary junction. It's the same one from yesterday's lecture, but just in case you need that information, but you're looking at this one. So you can see cranial nerve 5 easily, or a lot of times easily, when you're looking at a medical image. So you can look for the shape of the brainstem, will help you know where you're located. Look for the cerebellum, certainly does help, but a lot of brainstem sections when you're looking at a medical image will have the cerebellum in it, no matter where you're at. But you can see the basilar pons here and the cranial nerve 5. It's a large structure and is going to come out of the lateral aspect of the brainstem. Okay. All right. The other parts of the pons, most of the more difficult structures are on the posterior side, because you have the opening of the fourth ventricle, the floor being called the rhomboid fossa, and you can only see it again when we remove the cerebellum. And when you're looking at the posterior part of the pons, you're looking at the area that's called the tegmentum. You're looking at the part that all the cranial nerve are down into. So you're going to see swellings where you have cranial nerve nuclei, for example, the abducens nuclei in that region. It should clue you in to the underlying anatomic structures that are within this part of the brainstem. And we'll learn these. We're going to learn these in lab. I just pointed out a couple of the big ticket items here. The facial colliculus is the swelling or enlargement where the abducens nucleus sits. When we look at a cross section, what you'll see is that the facial nerve actually has fibers that wrap around the abducens nuclei. Nucleus is called the internal genu of the facial nerve. That's why they call it the facial colliculus, but it's annoying because it's actually the abducens nucleus that's sitting there. But once you understand that someone just, I really don't know why they did that, but it's just sort of a funny little anatomy thing, yeah. The sulcus limitans that we talked about before, that is going to separate the areas where you have motor function from the basal plate and sensory function from the alar plate, extends up in this area, and you can see it pretty well here in the floor of the rhomboid fossa. And the middle cerebellar peduncle is pretty big and easy to pick out even when the cerebellum is cut off. The superior cerebellar peduncle courses vertically and comes downward from the rostral aspect of the pons. So it's a little harder to point out on a cadaveric specimen. It actually looks best here in this diagram and drawing than I've seen it in even other drawings. It does not look that robust on most specimens, but we're going to help you find it in lab. Don't forget, neurons. When we say neurons, we mean there are cell bodies there. When we say tracts, we're talking about just axons. So there's no synapses happening. We just have information coursing up or down from one structure to another, okay? And this is a cool drawing. You can see collections of neurons here, collections of nuclei, all different types of pontine nuclei, and then you can see these axons that are coursing horizontally, most of which are going to converge into that thick middle cerebellar peduncle and make its way to the cerebellum. So we have this happening here. It doesn't really happen anywhere else in the brainstem like this. The pons ventricular system is all inclusive of the fourth ventricle. So the pons, it gets all the glory there and the expansion of the fourth ventricle. All right, so the pons has a basilar part that sticks out in the ventral side, and it has another area called the tegmentum. If you have to pick, you only had to learn one of them, you're going to want to learn the basilar part. The tegmental's got a bunch of nuclei just all squeezed in there in different fiber tracts, but unfortunately, we're going to have to do both. So when you hear the word tegmentum, it's referring to an anatomic region, and this tegmentum is in both the pons and the midbrain, but the midbrain also has another structure called the tectum. So in the pons, you only have the basilar portion, and you have the tegmentum, and you don't have the third because the tectum area, the roof in the pons, grew out to be the cerebellum. But in the midbrain, it didn't. And there are nuclei that reside there. So you end up with 3 regions in the midbrain and only 2 in the pons. So here you can see in cross-section the area that's the basilar pons. And you can see that we have some horizontal fibers and we have some nuclei that reside there too. Clinically important tracts being the corticospinal tract, corticobulbar tract, and we'll go through that. And then the tegmental area is where all of the cranial nerve nuclei that reside in the pons, which isn't, an extensive list, luckily. We have only a few we have to be concerned about, but then we have tracts that are also coursing through. So the nuclei aren't the only thing in the tegmentum. We also have tracts that are coming up and down. And then we also have special, that other category I talked about yesterday, I gave you some information on. You're going to learn more about these other category, like the reticular formation, like Raphe nuclei, and the neurotransmitter-specific neurons. You're going to learn more about them when you talk about systems and how they relay information at different places in the brain. I don't like to ignore them completely because people will use the terms and you'll be wondering, well, how come I don't even know where this structure is located at? So I introduce you to them, but really understand the depth of their function is going to be when you're learning about the different systems, like, for example, the locus cerebellum. Okay, so here's a question for you. Which region would you expect to find the corticospinal tract that is targeting the left side of the body? So here you have to think about, what does anatomic view mean? What does anatomic view mean to you? It means that they're on their belly. Okay? Okay, that's right. That's right, the ventral side is down. What about what direction you're looking? Are you looking from inferior superiorly, or are you looking from superiorly inferiorly? So you're looking from the head down, you're looking from the feet up? Head down? Okay. Dr. Ferris, is that right? Y'all? Yeah, go ahead.
You're always looking from the feet. Rotate 180 degrees.
You want to change your answer? Okay. You're always looking from the feet. Whether it's the anatomic view or the clinical / radiographic view, you're always looking from the feet up. So the only thing that's changed is that the picture is moved around. Okay? And you're going to ask, why do we learn it this way? I don't know. But when I was taught it, I was also taught the anatomic view from the get-go. And then I saw these questions, and it's like the picture's upside down, and I'm having to flip my brain around. So you're going to get the questions in both views, okay? And so looking at this one here, oh, that looked kind of cool. So looking at this picture here, where is the corticospinal tract? It's not going to be up here, right? Because this is going to be sensory. A lot of sensory information is going to be up here lateral. As you move more medial, it's going to be more motor. Oh, I forgot to ask you here. Where are we located at? We haven't done this one yet, right? So it's okay. But do you know where the corticospinal tract is? How do you know where the corticospinal tracts are? Somebody tell me why you know it's that. Because it's always ventral, right? It's always a tract that's very, very ventral. That was one of the rules from yesterday, that you can hold on to through the brainstem unless you're at the motor decustation. Okay, so the corticospinal tract is always ventral, and hopefully you're thinking this is ventral because you see the large fourth ventricle up here. So that's dorsal, and this is ventral here. So corticospinal tracts are down here. So really you're left with, what side of the body are you on? Well, if you're looking from the feet up, then this is kind of, flipped of the way that you want to see it on necessarily a radiograph. You're right, it's belly down, right? And so, see if it works this time. So 4 is the answer. So when an anatomic view, and it's upside down, this actually ends up being the left side of the body. Whereas normally when you would look at a cross section, let's say we were looking at well, let's just go to the next picture, okay? Now I flipped it. The same question, I just flipped it for you in a radiographic view. So here you have a radiograph, a MRI. The answer is now going to be different, right? Because we are flipping it to where this is, ventral is up, and dorsal is down. And so the corticospinal tract projecting, because it's going to cross to the left side of the body, is now in the upper left, which we're medical students, so it's what we think of as the patient's upper right. Are we okay with that? Yes?
So on the last one, if it was belly down and from the feet, how is the right side the left side of the patient?
Okay. Say the question again.
So you said if they're belly down and looking from the feet, I don't understand how the fourth quadrant is the left side of their body.
Because this track crosses. I'm not saying it's the left side of the body, but the track crosses. Oh, I didn't say that part? I'm sorry. Remember, the corticospinal tract is going to cross to the other side. I left out a very important part of this thought process.
Towards the right.
Huh?
Towards the right.
Yes. Yes. Okay. See, I knew I was going to mess up somewhere. Are we okay? All right. Everybody's good? All right. So 4 would be the correct answer in this case, but in a clinical radiographic view, if you're looking at, ask the question on a test or quiz or MRI, like on a radiographic view, then you're going to want to put 1. Okay. Glad we cleared that up. All right, so the basal part of the pons, the basal plate of the pons is going to have where the cranial motor nuclei are some nuclei that are only found in the pons. The abducens nucleus, the facial motor nucleus, and the superior salivatory nucleus. Okay, those are only found in the pons. They're not found in other places. So I didn't put in there. Well, I guess that's sensory anyways. All right. So I have a question for you here. What function does the superior salivatory nucleus have? Now we haven't done this nucleus yet. But we did a similar nucleus. We did an inferior one. Do you remember what that was? Okay, take a guess here. 5, 4, 3, 2, 1. Good. Most people got it correct. It's parasympathetic preganglionic innervation to lacrimal gland and most of the salivary glands, except for the one it runs through. So if the superior salivatory nucleus is in the pons, and so is the facial nucleus, the facial motor nucleus, it's not hard to link those two up and understand that that's how the parasympathetic fibers get onto the facial nerve as it leaves the brainstem. Right? So that this function of the facial nerve is not in the facial nucleus. It's in superior salivatory. Okay. The other answers are legitimate answers, but just for other nuclei. I didn't just make things up. Okay, there you go. The alar plates are going to have nuclei that you're already been introduced to, that you have been already introduced to, the trigeminal nucleus, because it goes almost throughout the whole brainstem, and also vestibular and cochlear nuclei, okay? The rostral tip of the solitary nucleus, which we talked about yesterday, is called the gustatory nucleus, is also located in the caudal aspects of the pons, okay? And what was that gustatory nucleus responsible for? Taste, no matter what cranial nerve it came in on. It's going to end up at that nucleus. Okay? It started in the medulla, it ends in the pons, and facial, glossopharyngeal, and vagus all convey some taste. So they have, So those nuclei are around, the nerves are going to be leaving, so it has to be in those two areas. All right, so again, we have ascending pathways in the pons that are just coursing through. We have descending pathways that are coursing through the pons, so this is all repetitive from yesterday. And now we can get to the nitty-gritty of what you need to know about the structures at each level of the pons. Okay, we have big players here. All right. So I'm going by layer. We have 3 different regions. So the first region is called the caudal pons. So it's going to be a section that's the most inferior. And then I'm going to talk to you about the part of the pons that we have clusters of nuclei or important tracts. And so I have caudal pons, and then I have tegmental area, okay? And I just want to point out here at the caudal pons, big ticket item, right away we have the abducens nucleus that's going to show up. So right away in the pons, when you're coming up from the medulla oblongata, you have the abducens nucleus that's highlighted here in yellow, and you can even see the wrapping around of the facial nerve, the internal genu of the facial nerve. It's coming from the facial nucleus, which is here, which I have highlighted on another slide. Okay. And just as your PowerPoint was before, I have links in here highlighted, hyperlinks where you can go, and it'll tell you a little bit about that structure, just to help you as you're going through, to give you something to hang your hat on. Okay, and so important part of the caudal pons that I can't stress enough is that you have the abducens nucleus and you have a facial nucleus that's highlighted in green. The facial nerve wraps around the abducens nucleus and is going to end up exiting the pons here laterally. In contrast, the abducens nucleus has its own nerve fibers that are going to exit in the course just lateral to the corticospinal tract, but they're going to come out the ventral aspect of the basilar pons. Do you remember looking at the brainstem and looking at the cranial nerve coming off? 6 came off the ventral, almost ventral medial aspect, and it's in line with 12, which is coming off of the medulla oblongata. So it doesn't come off the really far lateral side where 7 and 8 come off. Instead, it comes off closer to the midline. Okay, and that's what you can see that represented here in a section of the caudal pons. And you can see a lot of these things in these structures. I'm kind of ignoring this for after you already got down where this is located at. And your Haynes Atlas for lab also has really good sections in it. Okay. So if you're also looking at other parts of the tegmental area, you see some other interesting structures, like the superior salivatory nucleus nestled in right next to the facial nucleus. So you can see how those fibers just sort of hop along there. And then you have the medial longitudinal fasciculus, which isn't really super important to you yet, but it becomes more important when we get to the midbrain and we talk about well, it's important here because the abducens nucleus is here, and that actually participates in eye movements, and we have to have coordination between our 2 eyes together when we're focusing on structures and we're going gazing to different structures. So the medial longitudinal fasciculus is a big player in that, and Dr. Wyand will talk to you about that at length. And then the tucto-bulbal spinal system is nearby in dark orange. I didn't give you a lot of information, just give you a little bit about what that is, just because it's prominent there. If you're moving to the posterior lateral aspect of the tegmental area, you have more sensory nuclei, right? Okay, so this pattern is repetitive here. You end up with vestibular nuclei. There are different vestibular nuclei. I didn't have them labeled in there. I think Dr. Ferris, you're going to talk about each one and how they're different, or they just need to know where the vestibular nuclei are?
No, just the complex.
Okay. And then you also have the nucleus solitarius that is just anterior to those vestibular nuclei. What did that nucleus solitarius do? See if I have a question on that. No, I don't. Anybody? Special senses? Taste? Taste and smell. Okay, you got taste. So the most rostral aspect of the nucleus solitarius is the gustatory nucleus, right? But what about the rest of it? Because it's in a lot of sections. Anybody, huh? Tongue movement, well, look where it's at. It's sensory, right? It's way out there lateral, so probably not tongue movement, because that would be medial and probably hypoglossal. Anybody got an idea? GVAs. Those things nobody wants to talk about, visceral afferents. Coming in on cranial nerve 9 and 10 are going to come in, any GVAs that come into the head is going to come into the nucleus solitarius. And as a structure, it's kind of easy to orient yourself when you're actually looking at a stained brainstem structure, because it looks like a fried egg or salty peppery sort of salt and pepper little structure. So it's a good orientation spot because it's telling you where sensory nuclei are. Okay. All right. So I have a little bit of a blurb there about the nucleus solitarius here, and we just went over that in a question form. The central aspect of the tegmentum's got a lot of goods in there too. And I know, I'm sorry. So some of them you're not going to learn a lot about until later on, like the central tegmental tract and the superior olivary nucleus, which is important for the auditory system. But we already talked about the facial motor nucleus, so that's going to be in this area. And you already know about the spinal trigeminal nucleus and tract here. The rubrospinal tract, which is located here, right here, next to the anterior lateral system, will become important when we talk about the midbrain and you talk about how motor systems and how it helps with controlling motor movements in the body, not the head. Well, it might be the head. I don't know the answer to that. And then the medial lemniscus is your friend that is always going to be positioned somewhere. And here in the caudal aspect of the pons, it's just starting to get sleepy and want to lay down. So it's not laying all the way down, it's not even halfway, it's just starting to turn. So the medial lemniscus, remember, changes shape. The anterior lateral system's friend for a long time until it decides to become friends with the medial lemniscus later is the rubrospinal tract. Okay, so that they kind of go together quite a bit throughout this part of the brainstem. Now, if you're looking at the caudal part, we're still in the caudal part, but you're looking at the basilar portion. Luckily, this isn't too bad because you have the corticospinal fibers here, and then you have new nuclei that are called basilar pontine nuclei, and I talked about how the pons is connected to the cerebellum, so when you need information to get there, those pontine nuclei, they do a lot of things, but they are also going to be where the second motor neurons are located at for synapses to be able to project into the cerebellum. And then you can see that there are a lot of fibers. There are a lot of fibers that are going to be coursing from those nuclei in the middle cerebellar peduncle to make it to the cerebellum itself. And those, you can usually see them. You can see them on a cadaveric brain if you just cut through the pons, and you'll see these horizontal fibers just with the naked eye. All right, so now we've gone up a level to the mid-pontine region. If you notice, the fourth ventricle is starting to get smaller. So when you're looking up here, the fourth ventricle is getting smaller. You still have the rest of the principal or chief sensory trigeminal nucleus that is depicted here. You also have the nucleus solitarius, that's locus coeruleus, sorry. The locus coeruleus here, which my sections I put a black line around it because you can see those with even an unstained brain. It's a neurotransmitter specific neurons. And you'll learn more about those later. And I have some information in the slide if you click on it there. But you can see it so readily and easily that I have to talk about it because in lab you're going to cut through the pons. You're going to say, well, what is this? And well, that's the locus coeruleus. You're going to be able to see it right away. And then you also have a nucleus show up here at the mid-pontine region that's called the mesencephalic nucleus. That's associated with the trigeminal nerve. That's where the proprioception comes in to the trigeminal. It's a nucleus that handles the proprioception information. So that's important for that jaw jerk reflex that we talked about yesterday. Okay. Oh, and I forgot to talk about the motor nucleus. The other trigeminal nucleus that is important and this only comes in here at the mid-pontine region is the motor nucleus. So all the other nuclei, when we're talking about trigeminal, the principal or chief or sensory, no matter what it's called, is getting pain and temperature from the face, right, from the head, the head. The motor nucleus is the only part of the trigeminal nuclei that the motor neurons are located that will give innervation to the muscles of mastication. Remember the muscles of mastication and the other muscles that the trigeminal nerve innervates, like the mylohyoid and things like that. And so those are the three parts of the three trigeminal nucleus, the place where they're all together, all next to each other, even though the motor nucleus is motor. Okay. Now we're talking about the tegmental area and more of the ventral part of the tegmentum. Those other structures are right out here that we're talking about. Here's the middle cerebellar peduncle. The medial lemniscus is now completely lying down. So it was starting to turn in the caudal aspect of the pons, and here at the mid pons, it's completely horizontal. Okay, and then we also have the anterior lateral system here. I have them actually, I think, labeled on, no, I don't have them labeled on that one. I don't have them highlighted. Well, we have all the major systems. We don't have any new nuclei showing up. But I guess the change that I was trying to talk about is that the medial lemniscus is more horizontal, and we have the anterior lateral system starting to be broken up with the rubrospinal. Okay. And all of the tracts in the basilar part, I didn't highlight anything because there's not anything new. They're all the same, coursing through this mid-pontine region. So everything's similar. There's like a couple differences, but they're not clinically relevant, so I didn't go into that because even I didn't want to look up what they did. Okay, so now we have the rostral pons. So this is the rostral pons. We're going to transition eventually into the midbrain. The ventricular system is narrowing down because in the midbrain, the ventricular system is just a small canal, the cerebral aqueduct. So here we can see that it's really gotten a lot smaller. How do you know you're still in the pons? Look at the horizontal fibers coming through here. We're going to have pontine nuclei still interspersed with these horizontal fibers that are coursing to the most rostral part of the middle cerebellar peduncle. Okay. We still have part of the mesencephalic nucleus and tract that's located here, but it's squeezed real close next together to the locus coeruleus, which you can see with your naked eyes. You could find that in the lab section. And then we also have, let's see, a lot of reticular formation. I did not highlight the neurons of the reticular formation. I did I do have a slide on both the reticular formation and the raphe nuclei importance in this lecture at the end, where I have the tangent slides that you can look at and get more information about that, okay? And then the green aspect of the superior cerebellar peduncle. So I talked to you yesterday about how they have these three different peduncles, but it would be really great if the inferior one connected to the medulla, the middle one connected to the pons, and the superior one connected to the midbrain, but it's not that way. The very, very rostral pons is where the superior cerebellar peduncle comes into the brainstem. Okay, so the arterial supply of the pons is pretty easy, thank goodness, because the midbrain's more difficult. The basilar artery is going to course down the ventral aspect of the pons, that big basilar artery, and there are penetrating branches that wrap around and give blood supply to the parts of the pons. So it's really that fun. And there you can see it's from a oblique view. And this is what it looks like when you're looking at a cross section. So the medial aspect of the pons is going to be served by these paramedial branches of the basilar artery. And then you have two other branches that come circumferentially around this basilar pons. You have short circumferential branches and you have long circumferential branches. So the long ones are going to supply the most lateral nuclei, which you already know are sensory. So you can already start to see how you can segment how different lesions in these different vessels are going to cause different symptoms in patients. And so here is a classic pontine lesion, which would be the occlusion of just the paramedian branches of the basilar artery. It's also called the middle alternating hemiplegia. Remember, we had an inferior alternating hemiplegia yesterday. So now we have a middle alternating hemiplegia. And it's because you're going to have cranial nerve symptoms on one side, you're going to end up having sensory or motor deficits on the other side of the body. So you have in the head cranial nerve symptom, and they're associated with the cranial nerve at that level of brainstem, and in this case it's going to be abducens. And so you can see how these paramedian branches are going to service this area. The abducens nerve is coursing right lateral, just lateral to the corticospinal tract, right in that area. And so you're going to lose the abducens nerve. You're going to lose some corticospinal fibers. The medial lemniscus, which is up here, is also going to be affected. And so you end up having clinical observations of ipsilateral, which on the same side, loss of abduction, because the abducens nerve is going to innervate the lateral rectus muscle. Okay? And then you're going to have contralateral hemiparesis because you have the motor of the corticospinal tracts that is going to cross, and it's going to give innervation to alpha motor neurons in the ventral horn on the other side of the body. You have contralateral sensory loss because the medial lemniscus, those fibers have already crossed in the brainstem, and they're going to come up towards the thalamus, and you can't get sensory information from the other side of the body up to the thalamus. Okay, and don't worry so much about the horizontal gaze paralysis quite yet. All right, and then you have kind of lesser known syndromes here, where you just have the root of the facial nerve and corticospinal fibers affected, and so you wouldn't have it be involving the medial lemniscus essentially, and involving a facial nerve palsy and not abducens. And then if you have an occlusion of some other parts of the paramedian branches. So when you're thinking about, and they all say paramedial branches, but those were lots of little branches that were coming into the basilar pons. And you can have some of them that are occluded in one small area that went to this area, or you can just come right over to the lateral and you're hitting something else. You're hitting a different cranial nerve, or you're hitting a different part of the corticospinal tract, and so you can see different symptoms. So there's a lot of variability, but this one here is going to hit the trigeminal nerve. And so if you're hitting the trigeminal nerve, you're going to lose pain and thermal sense on the same sides. You're also going to have paralysis of the muscles of mastication. And because this lesion is going to affect the middle cerebellar peduncle, you also are going to have problems getting information to the cerebellum, and so you're going to have some ataxia. I don't know why I thought I had the red lesion area. I'll add that and put this back up. Okay, so here's a question for you. Which of the following patient symptoms would make you suspect that someone had a lesion in the pons? Only. We have no open. Oh, now it's open. All right, 5, 4, 3, 2, 1. Okay, most people put C, the ability to move one eye, because the abducens nucleus and the abducens nerve is in the pons, and it's only in the pons. And these other symptoms could also be argued that might be in other areas. And so that's how you can help differentiate and cross out distractors as not localizing symptoms. They might just tell you, okay, it's in the brainstem probably, but it's not helping you localize a lesion to just one place. Just a different way to think about it. Okay. So this is the slide where I'm just reminding you of that slide I gave you yesterday about how you will have cranial nerve lesion on one side and you'll have motor sensory deficits on the other. Because Dr. Ferris, from here on out, I'm giving you the baby steps, and he's going to just take you to where you need to go and give you lots of practice questions. Okay, I want to talk about direct hemorrhages. Just because I was trying to think of some clinical application that you might see. And I see these when I'm doing cutting brains a lot. And they're little tiny hemorrhages that occur in those branches, penetrating branches from the basilar artery. So that as those branches come in, they're real delicate. Anything that is going to shift the brain. So if you think about someone who has a lot of brain atrophy, an older individual, they have a lot of degeneration or brain atrophy overall. You remember those brains that were really much smaller? Think about how that shifts where the brain sits. And if you have a vessel that's pretty well fixed and little tiny things coming off of it and the brain shifts, you could have tears in those little delicate vessels, and it can cause little direct hemorrhages. Okay, not a harsh stretch. They look like this. We'll probably see some, and some. If I see any, I'll put them on the side so that when I'm cutting brains this weekend, so that you can see what they look like. Okay, and this is the normal. See how you can see the horizontal fibers coursing through the pons really easily, in contrast to like where areas where have pontine nuclei. And so other things that might make a brain shift would be increased pressure for any reason, bleeding, increased cerebrospinal fluid, or increase because of a mass above the tentorium, okay? And so that's another reason, but when I was talking with one of the pathologists who was teaching me neuropath, he said he sees them a lot in atrophic brains as well.